Hi, everyone. My name is Rahul Banerjee. I'm an assistant professor of medicine at the Fred Hutchinson Cancer Center in Seattle, Washington, also at the University of Washington in Seattle, Washington. And it's my honor to be speaking about Myeloma Awareness Month. Some call it Myeloma Awareness Month, some call it Myeloma Action Month. Either way, I think it's an extremely important opportunity for us to spread awareness and a call to action for better ways to diagnose myeloma, better ways to treat myeloma, and better ways to support patients with myeloma throughout their journey. 2024 is a very exciting year for myeloma therapy. I say that every year, but this month in particular, at the FDA in the United States, there'll be meetings and possibly an accelerated approval or expanded approval coming for CAR T therapy, idacaptogene viclucil and ciltacabtagene autoleucel in earlier lines of therapy, which I think is really exciting. I think for patients in the US, we've had many patients where, I think that CAR T is the best option for them, but because of insurance restrictions, because of restrictions on how the label is, because the newer trials of CAR T in earlier lines hadn't yet read out yet, we were kind of limited in our options for them. Possibly not any longer. I think that's really exciting, and I think that will be one of the biggest things to raise awareness of for patients in the U.S. to say, as our colleagues in lymphoma have said to their colleagues in the community, if they recur, you should refer. So for our patients with myeloma, as soon as they have a relapse, I think it makes sense to have those patients be evaluated at a CAR T or bispecific-capable center because of all these new opportunities that are FDA approved, let alone, of course, all these new clinical trials and products that are in investigation as well. So I think that's really exciting. I kept saying the word US and American. I mean, I think on the flip side of this, right, most of our patients around the world do not have access to CAR T. Sometimes do not even have access to daratumumab, a drug that I take for granted in the US. And I think one of the biggest things that we can do with Myeloma Awareness Month is hopefully at least identify, start to mitigate some of those disparities, because I do think that, as they say, I don't think any patient with myeloma should ever, pass away without an opportunity to receive a CD38 monoclonal antibody like daratumumab or cetuximab, just given how well they work. So that's what I would say in terms of the biggest things that Myeloma Awareness Month means to me. Some call it Myeloma Action Month, so I'll add that as well. I think for patients around the world, I think one of the biggest calls to action in my mind and out of my research is how do we make our clinical trials and what's in the book, so to speak, and in the regimens that the doctors at small practices use match what I would use. Examples that come to mind, we did research last year showing that 90% of physicians around the world prefer once weekly bortezomib, once weekly Velcade for their patients with myeloma, because that means less neuropathy, less time in clinic, and the patient does just as well. However, clinical trials continue to use twice weekly bortezomib, and I think a lot of doctors at smaller practices maybe don't know the literature, haven't seen this, or don't know that they're allowed to modify the trial protocol to match what makes the most sense for their patients. So in terms of Myeloma Action Month, myself and my colleagues, Dr. Kaur at UT Southwestern, Dr. Rajkumar has been a wonderful mentor at Mayo Clinic. We're working on how do we fix that? How do we make the best care treatment for patients with myeloma available countrywide and worldwide in terms of a drug like bortezomib? Another example, dexamethasone. I see plenty of patients who are on dexamethasone 40 milligrams per week for months, for years, despite the dose-to-dose anxiety, insomnia, high blood sugars that it causes. We've published work working with HealthTree showing that the more dexamethasone someone is on, the higher the risk of cataracts that interfere with their driving and their well-being. And in the, for myeloma physicians like myself who specialize in myeloma, we lower the dexamethasone all the time. We often say hashtag down with dex, as Dr. Mikhail would say at Mayo at TGen in Arizona. And so I think that is probably one of the biggest things I would say in terms of Myeloma Action Month is making sure that someone's zip code doesn't determine in the US whether they get once weekly versus twice weekly bortezomib, whether they get dex that makes sense for them or dex 40 milligrams forever. And I think that's kind of my call to action for all physicians around the country, around the world, is that take a look at what we're doing. I apologize on behalf of our field that our clinical trials never seem to match what we actually want to do for our patients in terms of how dexamethasone, bortezomib, carfilzomib are dosed. A story for another day. But I think knowing that for your patients in real life, your loyalty is not to the clinical trial, it's to your patient, and do what makes the most sense for your patient. And during Myeloma Awareness Month and Myeloma Action Month, that's what I'm most excited about.